Hey YouTube, it's me Sean. I'm doing a video because I said I would do a video about a care plan for OB. So that's what I have my care plan here, and it's an example of how, well, at least my school does the CareMap. It's not a care plan; it's a CareMap, concept map, whatever. So I'm gonna get a little bit more adjusted. Okay, so I think I'm just gonna go through it. Except for I'm not gonna go through the specifics, like the stuff that you can get from the chart, because if your care map asks for it, then I mean if you're doing a concept map and the information is in the chart, then all you're doing is copying. So yeah, so I'm gonna give you guys an example, and I passed this one. This is a mother baby. I passed a baby and a mom. So I only got like one or two more. It depends on if our unit is small. Where we at now? So okay. Okay. So it asks for the patient initials, their age, their primary diagnosis. This one actually said on the chart, how many weeks she was, and whether she was having an induction or not, and it says IUP. IUP is an intrauterine pregnancy, and they specify that because I guess there's been times where the pregnancy was elsewhere, not in the uterus, not just ectopic pregnancies. Like my instructor told me there was one lady who had it in her, I don't know, I forget. I want to say stomach, I don't know. Anyways, but yeah, so that's that. Then you put the newborn information, which is the age, the sex of the baby, the weight, and the gestation. And you put their gender. Then it says prenatal and labor and birth story. So you take what the patient says. So that's a good rapport thing to do. Like when you go in and you're talking, getting your vitals or whatnot, you can always ask her, how was the pregnancy, how was the birth, and get her perspective. If you need some more clarification or some more details, then as you either in that same setting or as you go in and out, you can pick up more bits and pieces by asking. And also in the chart, I forget what it's under, but you'll get it's called the labor delivery report or whatever. Then it's just a thing that physicians check or whatever. So basically what you do is just put it in, just state it. That's all I did. And if the chart says something specific that, I just put it in quotes as, the chart stated, or it was in the chart that, whatever. Because I know one time I had a labor, it said the labor was 300 and some hours and so many minutes, and I was like, that is not even true. But we figured out what her real labor time was, but when I was doing my care map, I forgot. So, and I couldn't find where I wrote it down. So I just put the chart stated she was in labor for so long, because, well, my instructor wants us to write down how long her membranes were ruptured, what was her estimated blood loss. Let's see. The length of her ruptured membranes, because that shows like how long she was exposed to infection. And then you have to get it says etiology and pathophysiology of a complication. On this one, I did preeclampsia for pregnancy, and I guess I can read it. I just said it's a condition unique to human pregnancy. Signs and symptoms develop only during pregnancy and disappear quickly after birth of the fetus and placenta. The ultimate cause remains unknown. The etiology is theorized to include various possibilities: abnormal prostaglandin action, endothelial cell dysfunction, coagulation abnormalities, vasoconstrictor tone, dietary deficiencies or excesses, immunologic factors, and genetic disposition may also play an important role. The pathophysiology reflects alterations in normal adaptations of pregnancy, With preeclampsia, the main pathogenic factor is not an increase in BP, but poor perfusion as a result of vasospasm and reduced plasma volume. And I just got it from my book, so I just put where I got it from and all the publisher information and everything else in the page numbers. And then you have to put the mom and baby's lab values, and you have to list their normals and you have to list the norm and then what was theirs, and you have to explain off to the side. So I know that was kind of quick, but so you just say, like, for the white blood cells, you're looking for signs of infection, a shift to the left. Hematocrit and hemoglobin, you're looking for an increase is due to a decrease in plasma volume and dehydration. A drop is normal in the woman after childbirth, but you don't want it to be in the single digits. And platelets, you want to know if she has an increased risk for a hemorrhage. So then the baby, I did let's see, Billy Flash. You could also, if it was done, you could do the baby's blood type, the negative DAT or direct antibody, direct Coombs test, that's what it's called. That's the one thing she said I should have listed, but I didn't know. But now I know. So, and I always keep my care maps for this one. The mom and OB care maps are more like med-surg care maps, except for you have 2 patients instead of 1, and one's a baby, and you're looking for different things in med-surg. They're perfectly well. The mom's healthy, provided she had no complications, but you're really just treating the fact that she had a baby. So that's a big difference. You know, on med-surg, everybody, I mean not everybody, but everybody's sick. Like they're not. That's why they're there. You know, they're not healthy. The pregnant woman comes in who happens to be pregnant, who happens to have to give birth. So therefore, that's why she's in the hospital. But other than that, she wouldn't have been there. So, but I keep my care plans because my instructor writes down like different, you know, little tidbits or whatever, like pointers or things we should include on the next one or to keep in mind. So I just go over the ones that I used to have and make sure I get the information I need that she said I missed, or if it's something else that I didn't do, then I will like look back and be like, okay, I'll make sure I put that in there. So it's a good thing to keep your care maps. Plus, it's always good to know when you pass a care map, then it's like, yes, you know, encouragement and to keep them just for reference. So then we have to list our drugs that we administered, and we have to put the lactation rating too. You have to put indications. Yeah, that's just part of that. Any allergies and possible drug interactions. The medical plan of care, that you'll find I know where to find it, but I don't know the tab, what it's called. But basically, you will look in the baby's chart and the mom's chart, and there'll be like a whole list of stuff. And you just pick out the basics. Like for the mom, I just said blood pressure medications, vitals, I&O, diet as tolerated, labs, hematocrit and hemoglobin and activity. For the baby, they're looking for bonding, glucose screening, antibiotics, erythromycin, vitamin K, hepatitis B, vitals, bilirubin levels, newborn screening, discharge. And that's not everything they had on there, but that's just some key ones. And then for the past history, this is the next section down here. For the past history, all you do is you put down like the mom's blood type, what their RH was, if they were immune to rubella, if their HBsAg is negative or not, GBS if it's positive, any other pregnancy history, like if the mom is like if she had, you know, a difficult pregnancy, or what was her difficulties, or, you know, whatever the pregnancy history is, or whatever the pregnancy was like, make sure you include that under the past history. Because excuse me, even when the mom is or even when you do a baby by themselves, because my instructor, clinical instructor, we did a baby first, or not a baby, but you either did one or the other first. And I did a baby first, then a mom, and then I did both. But when you do a baby care map focusing on the baby only, the baby's past history is the pregnancy history. So you would put all that information in there. Then potential complications, anticipated problems, or risk. Remember, this is for a mom and a baby, so I put risk for injury related to possible jaundice, roll strain related to family size. I put risk for infection, risk for DVT, risk for hypothermia, deficient knowledge related to infrequent feeding, fluid volume deficit related to delivery. Those are some of the possible risk, complications, or problems. Psychosocial, cultural issues. I'm not going to read this, but because you can pull this out of like from your rapport with the patient. So, and I do have like quotes in here and more personal information. So, but basically, like, you'll write down like, is she married? If she has adequate support, the bonding that you noted between the mom and the baby, any of those issues, like, psychosocial or cultural. Spiritual issues. I mean, my psych teacher said, pretty much with spiritual you're looking for, when need for meaning, I can't even think of it. It's like you need for forgiveness, need for love and relatedness, and a meaning and purpose. I think it's a need for purpose, or need for meaning and purpose. I don't know the official thing, but yeah, that's that. So, and also you could include feelings of like anxiety, overwhelm, or if they look distressed or whatever, you could put that in there too. And then for patient education needs, you could always teach them the signs and symptoms of jaundice, infection, how to basically take care of the baby, bathe, diaper, and dress. You can educate about immunizations, how to prevent infection, how to put the baby to sleep in the crib, teach mom signs and symptoms of infection and when to report to the doctor, how to care for her breasts, because if she's breastfeeding, follow-up care for, you can educate them on follow-up care for both the baby and the mother, treat signs and symptoms of hemorrhage, how to track the feeding times and how much the baby ate and voided to make sure they're getting adequate nutrition. So that's that. And then another little neat thing is we have this reflection and other observations, which is just a reflection is my thoughts and feelings, and observations are what did I learn and what did I expect. And this is the care map everybody, I didn't put that in there. Okay, everybody is talking about. So basically, if you get like an assessment sheet, if you have one, that's all you do for each of the categories. If you have an HFP, like I have one, I don't know where it's at right at this second, but I have one, and what it is basically tells you what falls under what category and what you should have under each category. But so that way when you do this, you know where to put it. You just go through your assessment or any other part that you've already filled in on your care map, and put it in here to support your 3 nursing priority diagnosis. So my top 3 was risk for injury related to possible jaundice for the baby, mom fluid volume deficit related to delivery, and number 3, roll strain related to family size. Yeah. But also make sure, even if the vitals, your assessments data are normal, like some of your nursing diagnosis, like my fluid volume deficit related to delivery, that one was a possible complication or risk. So like, but you could still like highlight or draw a line from that box to that, draw a line from this box to the number 2 diagnosis, because I put in information about her lochia and fundus, but I didn't highlight it to reference it to that diagnosis, because I figured, well, in reality, she has a risk for hemorrhage, but at the same time, like, that, what I diagnosed or what I saw isn't, indicative of, doesn't indicate like hemorrhage, you know what I mean? It doesn't really put her at a risk. It was a pretty normal finding, but you have to put all like risk or whatever assessment data to draw it to that box, at least for where I go to school. So that's what this looks like. This one is really not that bad. I like this CareMap for OB. For psych, it doesn't work so well, but whatever. Okay, so this is the other part. Basically, you're just telling your interventions. Let's see, for risk for injury related to possible jaundice, I put monitor the baby's bilirubin levels every 24 hours, and when there is an increase in visible jaundice levels. Teach mom signs and symptoms of jaundice, monitor baby's temperature and hydration. For 2, it was the risk for hemorrhage, but that's not how I stated it. But monitor the color amount and consistency of the lochia every shift unless there's a problem expected. Monitor vital signs and palpate the fundus every 2 hours or every shift unless there's a problem suspected. Then you'll do it every 2 hours. Teach mom signs and symptoms of hemorrhage and to report to doctor. And 3 was the role strain. Encourage family members to express feelings about altered roles and responsibilities. Explore with family members the ways the neonate will affect the family and structure functioning. And explore with the parents a possible plan to help with caring for the children and household duties. That one, the last one, I made up myself. The other 2 I got from Nursing Diagnosis Reference Menu by Sparks and Taylor, which I got the first semester of nursing, which is handy, but it's kind of, there's a new one out now. But anyways. So expected outcomes, which you have to list, and you have to give a timeline. So I'll read that real quick. Patient will continue not to have signs and symptoms of jaundice as evidenced by low bilirubin levels by 2-week checkup. And my instructor said a better way to define low bilirubin levels might be by stating that the bilirubin levels will be in the low risk zone on the bilirubin nomogram, which is just a graph, a chart. So when you check the baby's bilirubin levels, you have to like calculate how old the baby is in hours, and they turn a new age at midnight, or a new new age or stage, hours, whatever, at midnight. So then you calculate their age, and then you find their level, and then chart it and see where it falls on the graph. The other one, patient will not have postpartum hemorrhage as evidenced by firm fundus, vitals within range, and lochias within normal range by discharge. And patient and family will express need to assume new or altered roles and adapt to changes within family structure by discharge. And she says that your outcomes reflect problem resolution, have realistic and appropriate time frames, and have, as evidenced by, that uses the criteria that is based on the data that support the problem as a priority. So then on this one, you have to describe how one of the priority nursing issues may affect one or more body systems. And so I did jaundice and say how it would affect everything. I'm not going to read it though. And then you have to choose 2 potential complications for this patient and describe what nursing interventions may decrease or prevent the complication. I put risk for hyperthermia and deficient knowledge related to feeding frequency of the newborn. And I just put interventions to prevent that. And that's pretty easy. You only put like, well, for the baby, I put 1, 2, 3, 4, 5. That's pretty much keeping the baby warm and putting the skin to skin with mom. And then the other one, until awake baby, I just put 1 intervention. I'm not going to read my my narrative of my assessment because it's long. But let's just say she said these assessments are complete and the shift assessments are also complete. So that's that. That's how long my narrative assessment was. So, and on documentation, all I did, like, just keep it short and simple. Like, I'll read like a couple sentences. Let's see, baby assessments a baby assessment as follows: temperature, I listed it; pulse, I listed it; respirations, I listed it; skin is warm, dry, and intact; skin color, jaundice and pink; no edema noted; sutures override; fontanelles are soft and flat; neck, eyes, ears, and nose are symmetrical; nares are patent; spine is intact. I just was listing stuff down, and it doesn't have to be in complete sentences or anything. Just make sure that the next person reading this can get an idea or know what you assessed and that you were in the room. And that's it. It's not that bad. The new CareMaps, I think a lot of schools have switched over that, because I was on allnurses.com, and a lot of people were saying they were doing the concept map. It's not that bad, actually. I like it. It is a lot of paperwork, but if you break it down in sections and start on it early, like I highlight, I do like however much I can, and then that's my stopping point. And once I stop, I go back through and highlight what I need to finish. Then, so I can take a break or do whatever. As a matter of fact, I just remember I got my chili on the stove. So, okay, so 21 minutes I talked, and I still got chili on the stove that I forgot about. But yeah, so that's my CareMap. Yeah, it's pretty complete. I mean, it's easy once you get started. Yeah, it's cool. I like it. But yeah, so I'm gonna do another video and just give like a mini update about me, not like personally, but nursing school, and then I'll get back at you guys. Or well, and after that, yeah, I'll do a video like after my spring break. Alright, I'll talk to you guys later. Bye.